The anatomic alterations of the lungs in ARDS include interstitial and intraalveolar edema and hemorrhage, alveolar consolidation, intraalveolar hyaline membrane formation, which causes stiffening of the lungs, pulmonary surfactant deficiency or abnormality, and atelectasis. The etiology and epidemiology and clinical manifestations. There are over 60 possible causes of ARDS, but the most common causes are pneumonia, sepsis, severe trauma, aspiration, drug abuse, and oxygen toxicity. Clinical manifestations associated with ARDS usually appears within 6 to 72 hours of the incident, and it worsens rapidly. The patient will usually experience shortness of breath, cough, chest pain, cyanosis, tachypnea, tachycardia, diaphoresis, and use of accessory muscles and hypoxemia. To diagnose ARDS, they use the Berlin definition of ARDS. It is a diagnostic tool, and the requirements to diagnose the condition is the respiratory symptoms associated with ARDS has to have manifested within 1 week of the known clinical event or new or worsening symptoms over the past 7 days. The chest x-ray or CT scans must show bilateral opacities similar to pulmonary edema. It'll have like a ground glass appearance. Heart failure, fluid overload, and hydrostatic pulmonary edema must be ruled out, and moderate to severe oxygenation impairment must be present. This is determined by the ratio of the arterial oxygen tension to the FiO2 ratio. And the severity of the hypoxemia defines the severity of ARDS. This is the severity guide for ARDS. For mild ARDS, it's classified with a PaO2 or FiO2 or PF ratio of greater than 200 millimeters of mercury, but less than or equal to 300. And this is while the patient is receiving 5 or more centimeters of water of PEEP. For moderate, it would be greater than 100, but less than or equal to 200. And severe is less than or equal to 100 millimeters of mercury for the PF ratio. General management of ARDS includes in treating the underlying condition. You want to treat the condition that caused the ARDS first, or nothing else is going to matter what you do with ARDS. So you have to treat the underlying issue, whether it be the sepsis or hypoxemia or anything else. Mechanical ventilation with full support is usually necessary for patients with ARDS, and we will use a volume limited or pressure limited mode. We're going to consider moderate to high FiO2s with low tidal volumes of 4 to 6 mL per kg of their ideal body weight. We'll use high rates, usually between 20 to 25, and sometimes higher, up to 30 to 35 if needed, to maintain adequate minute ventilation, just depending on what their tidal volume is and how their ABGs are looking. And we want to maintain a plateau pressure of 25 to 30 centimeters of water, and high levels of PEEP may be needed to oxygenate the patient if the PF ratio is less than 200.